All right, 10 participants already.
Cool.
And Dan, just so you know, okay, I was just making sure you knew you weren't in present mode yet. Okay, perfect. Now I can see your slide.
We'll be getting started in about 2 minutes, folks. Yeah, might as well make sure that works.
Dan, is your background any place in particular?
Yeah, that is the big tree in Boone County. It's out by the Missouri River. It's actually the largest tree in Missouri.
Oh, cool.
This last week, it was struck by lightning, and it was on fire.
Wow.
The fire department had to go out and put it out. So it's got a big black scar at the base of it now, and we're not sure if it's going to make it.
Is it still the largest tree in Missouri?
Yeah, it didn't knock any branches off or anything like that. So
Cool. $22, pretty good, Dan.
yeah, we're right at 7 o'clock. Let's give folks 1 more minute and then we'll get going. Good evening, everyone. Welcome to IBD in Focus. This is the first of a 3-part educational series for Crohn's and colitis patients. I want to briefly thank our sponsors. These events would not be possible without their support. Takeda Pharmaceuticals, Janssen of the Johnson & Johnson Corporation, and Gilead. We thank you so much for your support. I want to introduce Paula Eckholz. She is the Executive Director of the Mid-America chapter, to tell you a little bit about the foundation and our chapter locally.
Great. Thank you, Dan. And just want to add my welcome to everyone for joining us here tonight. We have some fantastic speakers for you. We're excited Dr. Rood and Dr. Utterson are here. And just wanted to let you know that we definitely have other activities going on in the area. So even in this kind of socially distanced world, we're still holding virtual events and doing some fun things. So wanted to encourage you to reach out and get connected with us here locally so that we can also help you connect with other people who are passionate about finding cures for IBD and improving the quality of life for people living with these diseases. So just wanted to say hello and introduce myself, and then encourage you again just to reach out so that we can help connect you with our Take Steps event in the spring, which is a walk that we do, as well as our Evening of Hope, which is right around the corner, coming up on November 7th. And it's virtual, so you can sit in your pajamas and watch our gala this year. So there'll be information on our Facebook page and on our website and everything, and just would love to get to know you all. So definitely wanted to say hello tonight and just welcome you and turn it back over to Dan to get to the main event.
Thank you, Paula. Our first speaker tonight is Richard Rood, MD. He is a gastroenterologist and professor at Washington University School of Medicine. He's also a volunteer of the Crohn's and Colitis Foundation. He currently serves as the chair of our chapter medical advisory committee and is a former member of our National Board of Trustees. Thank you so much for your decades of service to IBD patients, and welcome to our virtual stage. Dr. Rood?
Thank you. Thank you. See if this works. Oh, all right. Everybody see the slides?
We do.
Good, good. Well, thanks for having me, folks. My job tonight is to give a primer on IBD. A lot of this will be some review for an experienced IBD patient, but there's some new stuff in here too. And then what we'll discuss towards the end is, what do you do if you lose your insurance? And since the gentleman at 1600 Pennsylvania Avenue did get his Supreme Court justice placed on the court, it is possible that the Obamacare as we know it today may cease to exist, in which case this may happen to a lot of people. So we'll talk about that in a little bit. Let's see here. All right, so just to tell you a little bit about me, I'm one of us. I developed ulcerative colitis when I was 10 years old. Medical management at that point were steroids, azulfidine, and if those two things didn't work, you went to surgery. And so when I was 13 years old, I had a total colectomy and endoleostomy. And as such, I have been a 50-year ostomate. I am now father of 3 grown kids and grandfather of 6, last count. And I believe as of Saturday, I will have 5 granddogs. My son's picking up his second. So I am an IBD gastroenterologist, and I've been taking care of IBD patients for the last 32 years. Let's talk about IBD. What is it? You'll sometimes hear people use the term irritable bowel disease. It is not irritable bowel syndrome. That's something entirely different. These are inflammatory diseases of the GI tract. The 2 major ones are ulcerative colitis and Crohn's disease. These are generally now managed medically, as differs from what I went through 50 years ago. But these are chronic illnesses. Now, that sounds awful, but in reality, in medicine, we don't cure a huge amount of things. We can cure some cancers, we can cure infectious disease, at least bacterial infectious disease, but some other things we treat. We treat diabetes, we treat hypertension, So the fact that these are lifelong diseases shouldn't shock anybody. Potentially ulcerative colitis can be cured surgically, but we'll talk about that in a couple of minutes. These are diseases of developed countries. There are 10 million patients worldwide with IBD. IBD occurs more in people who are Caucasian, Ashkenazi Jews, although other racial and ethnic subgroups are becoming more and more prevalent in the IBD community. In the United States, we expect there are approximately 3 million, with a US prevalence of about 1.3%, which means that in the general St. Louis area of 2.8 million, we expect there are about 36,000 IBD patients, if you do the math. There are 70,000 new patients diagnosed per year, and 80,000 of those are kids of the total. Ulcerative colitis is slightly more male, Crohn's disease slightly more female. These have what we call bimodal incidence, so it occurs most characteristically in the teens and 20s, but there seems to be a second peak about the mid-50s. It attacks people in their prime of their life and prime of their development, particularly in youngsters. As I said, there are two major varieties of inflammatory bowel disease, ulcerative colitis and Crohn's disease. As differs, ulcerative colitis is a colon-only disease. No colon, no colitis. It affects the innermost lining of the colon. It is a continuous disease, and what I mean by that is it's worse at your bottom and gets better as you go up the colon. It is, and I'll put in quotes, it's curable by colectomy. No colon, no ulcerative colitis, but there are some trade-offs. And these patients have frequent bleeding, but usually don't bleed out to drop their blood count significantly. Crohn's disease, however, can affect anywhere between the mouth and the anus. It affects the full thickness of the bowel wall. It can be in one area and skip, have another area. It is not curable by any fathom of the imagination. And these patients with Crohn's disease don't bleed as frequently, but when they bleed significantly. And why that is if, as I said, it affects the full thickness of the bowel wall. And so consequently, you can get an ulcer into a major blood vessel because you can get deep enough into the bowel, so you have a significant amount of bleeding. Ulcerative colitis symptoms: diarrhea, rectal bleeding. As I said, the rectum's always involved. It's superficial. If severe, it can become what we call toxic megacolon, which is where the colon bags out like a big balloon and ultimately perforates if not taken to the operating room for emergency surgery. The job of the colon is to absorb fluid and electrolytes from the GI tract. So consequently, not a lot of malabsorption usually happens in patients with ulcerative colitis, as differs from Crohn's disease. And it's classified by the extent of disease. So proctitis rectum, left-sided ulcerative colitis up the left side, and pancolitis the entire colon. Crohn's disease, our symptoms are dependent on the side of the GI tract that's involved. They too can get diarrhea, rectal bleeding, abdominal pain. If the upper tract is involved, which is a little unusual, but can be involved, they can have ulcer-type symptoms. In this situation, nutrients are absorbed from the small bowel, so this becomes very important relative to you can only take out so much small bowel until you become short bowel and have a nutrition problem. Crohn's disease is also classified by the extent, as well as what kind of Crohn's disease it is. Is it inflammatory? Is it scarring or fibrostenosing? Or is it fistulizing with little connections between bowel and whatever's next to bowel? How do we make the diagnosis of inflammatory bowel disease? Obviously, the most common thing is a colonoscopy, but if the upper tract is involved, we will do endoscopy. There is radiography, so x-rays, CT scans, MRs are done. Occasionally, we will do what we call capsule endoscopy, where the patient swallows a capsule that takes so many pictures a second as it's going down the GI tract. And we also use inflammatory markers in both the stool and the blood to both make the diagnosis and follow the disease. So what medications might you be on to treat your inflammatory bowel disease? Well, basically, we start with the simplest ones first and work up the paradigm. It used to be that we would say we start with the simplest drugs first and work up, as we call it, bottom-up approach. That has gone by the wayside, and basically we treat aggressively up front, but for the purposes of our discussion today, we'll start with the simplest ones first. So our first drugs, probably the earlier ones that came out, were the 5-ASA compounds, commonly known as mesalamine. Mesalamine, 5-ASA is like aspirin, but is not aspirin, and aspirin doesn't work. And what these compounds do is they affect the production of chemicals such as prostaglandins, which are inflammatory chemicals. These drugs work reasonably well in mild to moderate ulcerative colitis. They do not do well in Crohn's disease. And for the most part, the differences between drugs are based on the delivery system that particular pill is designed so it gets released in the colon, since these are drugs that work in the colon. They have minimal side effects. They do have renal toxicity or kidney toxicity, but in general are pretty well tolerated, since predominantly they are not absorbed, although they can get absorbed somewhat, and that's how they end up giving kidney toxicity. The next group of drugs, and probably about the same age, are the corticosteroids. They come in various shapes, sizes, and ways of administration. The ones you'll know most will be prednisone. There's a new drug called budesonide, which is a systemic steroid, but that particular steroid gets broken down very rapidly by the liver. So we think it's somewhat safer and has less steroid side effects. Steroids are drugs that are very good for getting a patient under control, but they do not maintain remission. So they're short-term fixes, not long-term fixes. Taken long-term, you can get diabetes, bone and joint injury, and cataracts. So it's something we try to get the patient on and off as quickly as possible. The next group of drugs down the list, and also probably during development, were the immune modulators. They include such drugs as 6-MP or pyranethol, azathioprine or Imuran, and methotrexate. In general, in 2020, they're used as a second drug to augment the effect of the biologics that we'll talk about in a minute, and particularly to prevent antibody formation against our oldest group of biologic drugs, the anti-TNFs. 6-MP and azathioprine can be used as single agents for both Crohn's disease and ulcerative colitis, although I do not believe they are done that frequently anymore, because I think our biologics are probably better. They do have problems relative to bone marrow toxicity, and there's a risk of non-Hodgkin's lymphoma or lymph node cancer with that, and some infections. Methotrexate is another one that we're using, predominantly also used as a second agent The liver is its major toxicity, but it also has to be avoided in pregnancy. It's one of the few drugs that actually does have to get avoided in pregnancy because it causes miscarriage. In fact, sometimes that's used therapeutically for that reason. As I alluded to, we have the biologics. The biologics have been around since the late 1990s, early 2000s, the first of which was Remicade. These are what we call monoclonal antibodies, or antibodies that are made in a test tube, and they are directed at different inflammatory chemicals. And the idea being is that the monoclonal antibody grabs onto the inflammatory chemical, and the body itself gets rid of both the chemical and the antibody. And by doing it, the inflammatory process downregulates. The first group of drugs, as I said, the first drug was Remicade in the IBD realm. It was followed by Humira and Cimzia. There are now what we call biosimilars, and you're going to hear about this more and more as time goes on. Biosimilars are to biologics to a degree as generics are to regular drugs. The problem is these are very complex proteins with multiple folds and bonds and whatnot, and it is difficult to make an identical copy. So these biosimilars have come on the market, theoretically should be less expensive than the original drug, or what we would call the originator. Although having said that, they have not seemed to take over the market as much as you might expect. And I think their philosophy has been they will decrease the price somewhat, but probably not more than about 20%. And as such, they just are not out there by leaps and bounds, although in certain areas we see more than others. They are good. Some of them, for instance, Inflectra, which has been well studied in IBD, I think is a solid drug. Some of the other drugs can get released by the FDA because of research in another disease and get approved in IBD without IBD studies. So some of the other ones may not have been as well studied. Our next drug down the line, not necessarily in order, is a drug called Stelara. Stelara is also a monoclonal antibody that is active against two inflammatory chemicals, IL-12 and 23. And it would appear that IL-23 is a hot area for future development. There are now, I believe, 3 drugs that are in development just going after IL-23, and is actually a drug that's a small protein that's an oral agent, interestingly, that we'll be studying at WashU, that is going after the receptor that IL-23 binds to. So theoretically, if you block the receptor without stimulating the receptor, then what happens is you can have as much IL-23 running around as it is. If it can't get to its receptor, then the inflammatory process doesn't occur. So that's the theory behind that one. We have the anti-integrins. The most common one we're using now is Entyvio, but Tisabri was the original. These are basically traffic cops at the lymph node level and basically get lymphocytes, which type white cells, stuck in the lymph nodes. If they can't get out to the area where they're causing inflammation, the inflammation downregulates. Entyvio is interesting because it's gut specific, which is good and bad. The good news is it's safer being gut specific. The bad news is is if you have a patient with associated problems, including arthritis or skin problems associated with the IBD, unless the IBD getting better makes those situations better, it will not affect some of the extraintestinal manifestations. So the last drug out currently is a drug called Xeljanz. It is what we call a JAK kinase inhibitor. There are 3, possibly 4 different JAK kinases that it inhibits. It right now is indicated only for ulcerative colitis. It works very rapidly and is an oral agent. So because it's not a biologic, you can't get antibodies against it. As I said, it works rapidly in the first week, only seems to work in ulcerative colitis and maybe a couple subsets in Crohn's disease. However, in what we call phase 4 trial, what phase 4 trial is trial after a drug has been released by the FDA in rheumatoid arthritis in patients who were over 50, had a cardiac risk factor, and were on 10 milligrams twice a day of drug. There were excess pulmonary emboli, which are blood clots to the lung, and deaths. So, that's a lot of qualifications to get to that, but you wonder if this is going to be a drug that's going to stick around for the long haul. The pulmonary embolus issue may be a class effect, and what I mean by that is other JAK kinases, at least one other JAK kinase, also had a pulmonary embolus issue. So we'll see. The good news is it works quickly. The bad news is if you have to stay in the 10 milligram twice a day dosing and you're over 50 with a cardiac risk factor, I think you have to think real hard about whether you want to be on this drug or not. And these need to be avoided in pregnancy. Here's just how they size up relative to diseases we use them in. Most of them cross over except for Xeljanz and Cimzia, which do not cross over. Some are better than others. For instance, in my opinion, I think Humira is probably a better Crohn's disease drug than ulcerative colitis drug, and Entyvio may be the reverse. Entyvio may be a better ulcerative colitis drug than it is a Crohn's disease drug, although the studies that originally presented to get these drugs to market were done a little differently than we treat patients now. What I mean by that is they had fixed dosing. So nowadays, we don't give up on a drug until we have drug levels and we've increased the drug dosing and done a lot of things to see if we can salvage that particular drug for that particular patient. And the reason we do that is, as you can see by these 2 lists, I don't have an unlimited number of drugs to work with. And patients over time will burn through these drugs. So that's an issue. As we said, the biologics are foreign proteins to our bodies. And since they are foreign proteins, our bodies will make antibodies against these foreign proteins. And when that happens, the drug dose goes down and the chance of having a reaction goes up. This seems to be predominantly a anti-TNF, so Remicade, Humira, and Cimzia issue, less so for the newer drugs, Entyvio and Stelara. Interestingly, there is one drug that is a designer drug for a pregnant woman with Crohn's disease, and that happens to be the drug Cimzia. Because if anybody remembers what an antibody looks like, it looks like a Y. And the top part of the Y is what binds to things, but the bottom part, the tail of the Y, is what's necessary to bind to the placenta and get across to the baby. Cimzia doesn't have the tail. So since Cimzia doesn't have the tail, Cimzia chemically can't get to the baby unless there's a break in the integrity of the placenta. So, if there's a abruption or something happens to the placenta, then yeah, the baby can get some symptoms, but in general, it's relatively safe under those circumstances. There are biologics have risks. They include neurologic problems, mostly infections, hepatitis B and zoster. And there are risks of lymphoma, both melanoma and non-melanoma skin cancer.
Dr. Rood, we've got 3 minutes until Dr. Utterson begins.
Okay, thank you. Let's go down here to what do you do with loss of insurance? First of all, avoid this if at all possible. Consider COBRA coverage if that's an option relative to your employer. Obviously, vote. If we lose ACA, we're in deep doo-doo, and that may happen. So, and it's not necessarily that there's insurance available. The insurance has to be available at a price you can afford. Because the insurance isn't available at a price you can afford, it's like having no insurance at all. Avoid lapse in insurance coverage as best as you can, because in the olden days, that was a reason to be cut out. Remember, each time that one changes insurers, we have to go through the pre-certification process for biologics. And as such, prior authorization has to be started all over again. And I will remind people there is a Safe Step Act in both Congress and the Senate that we're trying to get co-sponsors for. I talked to Senator Hawley's people about this. This is to prevent insurers from not giving you the right drug for the right indication that your doctor wants you to have. Options, if you lose insurance, there are randomized controlled trials. These are generally placebo-controlled, which I mean, so you get a dummy drug, half the people or a third of the people. And the good news is that if you make it through that part, there is an option to go on open label drug, and basically you get that drug in general until the drug goes to market. In the next couple slides, and I'll go through these reasonably quickly, these were put out by Dave Rubin, who's the incoming National Scientific Advisory Committee chair from the University of Chicago, of all the websites that you can get compassionate drug from. So this is the first slide. This is the second slide with both the websites and the telephone numbers you can go if you lose insurance and need to go that direction. Finally, this is the last one. These should be available to you through Dan. So if you need the telephone numbers or the URLs, they're all listed out for you. And since I am an ostomy and the chairman of the medical advisory board for the Ostomy Association nationally, I give you the three major ostomy equipment suppliers, and these are their websites, and they certainly all have compassionate programs when people lose their insurance. A minute for advocacy. Both of these organizations are incredibly important for all of us, both the Ostomy Association and the Crohn's and Colitis Foundation. These are the people who bang on the offices in Washington, D.C. to make sure we get the medications and the equipment we need to adequately treat our disease. This is what I used to do. I used to be on cruise ships 3 times a year. Unfortunately, this is what I do now. So thank you very much.
Thank you, Dr. Rood. I want to welcome Dr. Elizabeth Utterson from St. Louis Children's Hospital and Washington University School of Medicine. And she has 2 patients to join her this evening, Elizabeth and Zoe. Dr. Utterson, also should be said, she is one of our most important volunteers. She is our Camp Oasis medical director and in charge of the kids' medical well-being while we're at Camp Oasis in Missouri every summer. Dr. Utterson?
Thank you, Dan. I appreciate it. And thanks, Rich. That was a great presentation. So last year, I think we did a video. I was at my national meeting for pediatric GI. So I wasn't able to be at the education program, but we did a video. And how I did it was we talked to a couple of my patients and focused on, certainly they both had undergone some surgery. And we talked a little bit about, being in the hospital, having surgery, things like that. So we had to do a reunion because it was so well received. And so I've got my two girls here, and we're going to talk a little bit about just different things that we think would be important for you all, perhaps dealing with a new diagnosis or dealing with, different social things that would come up potentially in the pediatric age division. This also can apply, to things that work when we talk about school. So I'm just going to throw out a few questions. And I think the girls' real life and real world answers are speak for themselves. So the first thing is have to talk that these girls are just fantastic patients. They're very good. They have wonderful families. They're both 11 and they're very precocious for their age. So you're going to see that now. So anyways, first to start off, just wanted to talk about both of you were diagnosed when you were pretty little with inflammatory bowel disease. And what do you remember about that whole thing now? Is it a blur, or do you remember some distinct things? And if so, what can you tell us?
I don't remember a ton of it, but I do remember not really knowing what's going on and kind of like, oh, what did I just get diagnosed with? I remember definitely taking a lot of medications and going to the doctor's office, not daily, but, just having appointments a lot. And I would also see a difference in when I would have to go use the restroom and stuff like that. But yeah, so.
Great. Good job. What about you, Zoe?
I remember always being confused about how my stomach would hurt so much when I had to use the bathroom. And I remember always running to the bathroom, and sometimes I wouldn't even tell people. I would just start running. So a lot of the times I would get lost and stuff.
Absolutely. It can get tricky. Absolutely. So what was it like to have things like tests, blood tests, MRIs, CT scans, colonoscopy, things like that? Was that something that seemed really foreign to you at the time, or do you think that that was something that made sense once it was explained?
I would say that I was a little confused on why I was getting a bunch of blood tests and everything like that. But once you kind of got used to it, almost, it was just kind of second nature, just getting a shot or anything like that. But yeah.
Mm-hmm. Absolutely. We hope as physicians that you do accommodate a little bit over time so that it's not a big, huge deal every time, but we know everybody's different with that. What about you, Zoe?
I was just afraid of big stuff and needles. So every time I got a blood test, I would always freak out. But then after it, I'll be like, oh, that was not that bad. But I would always freak out seeing the needle and being like, wait, what?
And did you watch it?
Yeah, I love watching now.
What about you, Elizabeth? Did you look away or did you watch?
I looked away. I was trying to get my mind off everything. I would look away and I would say, don't count, just do it. And don't even tell me when it's going to happen.
Yeah. Zoe, do you feel like over time that you got kind of smart to say, last time it wasn't bad, so I shouldn't get upset? Do you feel like that ever helped any of kind of that self-talk?
Yeah, like blood tests now, I'm not afraid because I know they hurt when the needle goes in, but that's the same with every other shot. So now I'm fine with it.
Good. Awesome. But it doesn't happen overnight. So it's different for everybody. And we have to understand that everybody's going to react differently. Okay. All right. Tell me about taking medication at home. And do you have siblings? Did they have to take medication too? Was this something that was a struggle at home? Did you take liquid? Did you learn how to swallow pills? Give me your thoughts on that, because that will appeal to a lot of people.
Well, there's definitely a lot of medication trials and like taking different medications. But if you ever have to take like a medication that doesn't really taste that good, which you probably eventually will have to, but having a little ice cream after it or having something sweet, like it would make it so much better. Like seriously, I would have some ice cream after I took like a liquid medicine or something like that, because at the time I couldn't swallow pills, which was hard. But yeah, so anything sweet kind of makes it better. So
you had an ice cream chaser. That's awesome. Okay, Zoe, what about you?
I always go for the method to just kind of go for it, because like if you take little small sips or just like leave the pill in your mouth, it will just get worse. So I just try to go for it, because then you don't have to taste it as long. And like Elizabeth said, having something like sweet or something yummy after helps.
What's your pick? Is it ice cream? And if so, what flavor?
Sometimes it's ice cream. And if it is, it's normally strawberry, but sometimes I also like eat a spoonful of sugar or something.
Helps the medicine go down. Yes. Okay, cool. And Elizabeth, I don't think we asked you what kind of ice cream you like best.
Chocolate.
Okay. Okay, good. We got some good standards here. Okay, so and then do you both swallow pills now, or did you before, or when did that happen, and how did you learn?
I still have not learned. I do not. It's kind of one of my fears. I do not like having swallowing, but I think I should learn definitely soon. My sister tried to teach me by putting an M&M in my throat and like was like, swallow it. You have to swallow it. So I did, but it was not the best approach of like forcing me to swallow it. But when I was in like kindergarten and first grade, I definitely like did not know how to swallow pills, but for some medication, you could crush the pill so you wouldn't have to take the liquid, which was definitely a lot better than taking the liquid. So, yeah.
Okay, what about you, Zoe? Do you swallow pills? And if so, when did you learn how to do this?
I do swallow them, and if they're big, sometimes what helps is just getting like more water or whatever you're swallowing it with. And I think I started swallowing when I was like 6 or 7.
Cool. And how'd you learn?
I actually have no clue.
It just happened.
I guess I just one day swallowed it and then I just started doing it. I don't really know.
Hey, good. I'm glad it wasn't a big struggle that you remember. Okay, good. So yeah, it does sometimes go a little bit easier when you can swallow them. You don't have to do as much tasting and such, but there are alternatives. And Elizabeth, we got your back, girl. So we're all good. Okay, so tell me a little bit about, did you ever have to go into the hospital? And if so, what was that like? And were people nice to you there? And was there anything good about the hospital? Those types of things. Maybe Elizabeth start, since we've been starting with you, girl.
Okay. Well, I definitely had to go into the hospital like a fair amount of times, but it was they were all of the staff and nurses and doctors and everyone in the team was really nice. And like when I had to stay overnight, that you could just like the food was on the hotline. You could just call it up and like say, okay, can I have a pizza, a smoothie? It was kind of fun, but yeah, but everyone was really nice. And the playroom was really fun too. Like going, when you had to stay overnight, you could go to the playroom and the library, or like the mini bookshelf and like library thing. You could rent books. So that was fun too. But yeah.
But are doctors allowed in the playroom?
Yeah, I think they are.
No, I am banned from the playroom.
Wait, actually? Oh.
Yeah, no, I get nasty grams if I go in the playroom, but it's good because you guys need a place where we do not intrude. So
True. I did not know that, but
yeah. So just so you know that. So there are some good things. And then does anybody remember what happens on Wednesdays at 1 p.m.? You might not remember this, but
Bingo.
that's right. This is at Children's Hospital. Bingo. And what might you get to win on bingo?
I got a gigantic unicorn onesie.
Oh, nice. So yeah, when you go into patients' rooms at 1 p.m. on Wednesday, like try to just not interfere. You know what I mean? Because they're playing the bingo, and I've seen some of those prizes. They're pretty good. Okay, Zoe, tell us, did you ever have to go into the hospital? Sounds like you played some bingo.
Well, especially after my surgeries and stuff, but when I was going in for other stuff, at first it was really scary just being in a hospital and not like at home. But after a while, they make you feel really comfortable. And one of my favorite things about staying overnight is you could ask for like 70 blankets and you would just be so warm. And then about the bingo, I won a Lego set once, so it was fun to do that with my mom.
Mm-hmm. Absolutely. And do you remember other things, doing any kind of crafts in the hospital, or do you remember the Child Life Services bringing any cool stuff your way?
The Child Life normally brought like cool crafts. So like I got to put glue on a piece of paper and then like sprinkle glitter all over it, which was really fun. And then one of my I think it was my dad, he went out and read a book to me at the garden. The garden is really fun.
Where's that?
It's right by the playroom, and then you just keep walking, and it's
Cool.
like, yeah.
So it's outdoors, up high.
Yeah.
The garden was definitely one of the best places ever. Like you could just get some fresh air and away from like your room. And I spent like probably a lot of my time up there. And it's a really good view. So it's nice.
And just for patients that might be listening, do you have to stay by yourself in the hospital?
You should always have like a parent or like a nurse or someone there with you. You shouldn't be by yourself usually.
Yeah. So, and some parents, they're just too busy and they've got other kids at home, and we know that. We've got some volunteers and the nurses. I even have gone in and sat and played with kids for a while. So the one thing about it is we expect that probably some sort of caregiver will be staying with you, so you won't be alone. So I think that's important to hear. Absolutely.
The only time I'm ever alone is if my mom was like gonna bring me something from home that I wanted, and I could always just call in a nurse if I wanted company or something, and they weren't busy.
Good. Absolutely. Okay. Awesome. This is good information, I think, for everybody to have. Tell me, when you were diagnosed and things like that, who helped you? Like, who helped you kind of navigate things, both at home and at school and things like that? Who did you kind of lean on for support, or maybe who did you let know about this? Because not everybody has to know or does know about something like this going on with your insides.
Well, obviously my parents knew, and obviously like they were definitely there and like very helpful. But I guess like outside of like my family, teachers were like someone that I let know kind of what was happening. And I talked to them of like, hey, I might want to be closest to the bathroom, or I might want to just have to go more than other kids. And I might just have to get up and just like go without even you knowing. But I definitely told my teachers. And then eventually I did tell my class, and I was just kind of just letting them know like what was going on. But you don't have to tell your classmates or anything like that. I just chose to do it because I felt comfortable. But yeah, so that's who I told.
Great. What about you, Zoe?
I got diagnosed when I was 4, so my mom, my dad, and my teachers helped me a lot because they helped me also understand what was going on. Like even my teachers sometimes knew more than I did. And just when I was 4, my mom says that I would walk up to someone and say, "Hey, did you know I have UC?" So basically everyone knew.
That doesn't surprise me.
She said
That's
I
good.
walked up to someone at Walmart and said like something nasty about my UC.
It's okay. It's bringing awareness. Okay. All right. And then did you pick out teachers to tell, or did you pick out friends to tell, or did you kind of announce it to your class too? I know when you went, so for Zoe, when you went to kindergarten, did you tell people then, or did you feel like you kind of had the hang of it when you started school?
I think I started getting the hang of it at school because I realized that like people think different of you by the way you act. So I stopped like just walking up to people and saying, "Hey, did you know this?"
I think I started with like my teachers, and then I think I went to like my closest friend just because like I wanted to have a buddy if I like needed to go somewhere. So I told my best friend, and then I decided to tell my class, and that was just kind of because I felt comfortable and I just wanted to let them know like what was going on, especially like after my surgeries. I was definitely a little bit more like more not quiet, but just more, I don't know, something like that. But I eventually told my class and they all understood, and yeah.
Good. I've had patients that have told everybody, and I've had patients that haven't told very many people. And it's definitely different. I do think it's good to let somebody at the school know. And whether you go through having a 504 plan or what have you, I think that is a strength because it's going to allow you for some variation from your peers that is needed for something that is oftentimes hidden. So I would encourage a lot of our families and patients to look for some of those things. It's not a free pass. It's just realistic to help you have a little more time, do this, go to the bathroom when you need to, those types of things. And so I think that is one thing that can, lessen the burden a little bit as you try to navigate the world of Crohn's and colitis and going to school while you're growing and developing. So Dan, we may want to, I bet there's probably, these girls are going to attract some questions. And so I bet that it probably would be a good time to allow for that. Otherwise, we'll go past our time and we won't have the opportunity.
Great. If everyone would like to type a question into the Q&A box, if you have any, you're welcome to do that. Or a few people have put some comments in the chat box. Dr. Utterson, I think you were going to say something about Halloween and safe trick-or-treating and things like that. If you want to go ahead and say that and give folks some time to type into the chat box.
Sure. Perfect. So Halloween this year is going to be different, but what hasn't been different, I guess? Everybody's a little bit, kind of wondering what everybody else is going to do. I think that, certainly if you have some neighbors around that you've perhaps played outside with or interacted with, and you come up with a standard of, putting some candy into bags and not having a big bowl that everybody reaches in and things like that, I think you can make it work, much like some people are doing with pods at school for virtual school and things like that. I think that it will be hard to anticipate that we would do traditional trick-or-treating house to house, that people will be, certainly exchanging lots of different touching of candy, etc. But I think, talk to those around you, talk to those you've been associating with, and try to keep the smaller circle of friends and maybe turn it into a party where there's, some treats and such, and that we hope it's a nice night, that people can be outside, because I think being outside can allow us to socially distance still. And remember too, if you're going to be closer than 6 feet apart, the kids should put a mask with their outfit. And, it's one of those things where I think they're getting kind of used to it. And so it's not a foreign thing to them. And boy, there's lots of different types of masks and stuff now. So probably you could find one to accessorize the chosen outfit.
Thank you, Dr. Utterson. And we'll take any questions on Halloween related things as well. I'm going to start with a couple of the comments. Dr. Rood wants everyone to know that the Crohn's and Colitis Foundation has brochures specifically for teachers of kids with IBD. If anybody, actually, I will send it to you all, so you all have it, just a digital link to our brochure for teachers. We also have a similar brochure for parents of kids with IBD.
When I was in private practice years ago, I would take care of kids from adult size up, so young teens, mid-teens and up. And basically, I'd get a stack of these at the beginning of the school year, and I'd hand them out to the patients and the families. And the idea is to get it into the appropriate teachers in that kid's school so they get a little education and try to normalize things for our kids as much as we can. There should not be a stigma about going to the restroom. They shouldn't have to announce themselves, ask permission, let them go. And sometimes alternative restroom facilities, depending on what the facility of that particular school looks like, also have to be addressed. But the brochures, actually, I've probably spent 8 to 10 years on the patient education committee of the CCFA and hope to take over that committee in the next 3 years. So the brochures are actually pretty good. If they aren't, let us know and we'll fix them.
Dr. Rood, we have a question that came in for you. I recently spiked a UC flare over the summer. Can you explain why my blood work never indicated abnormal results, CBC, CMP, CRP, vitamin D, yet my CalPro stool test indicated inflammation?
Well, it's basically where you're measuring inflammation. So it may not have been enough inflammation to make the blood work change, but since you're measuring the inflammation right at the bowel level when you're doing calprotectin level, it can be more indicative of that's where the inflammation is coming. The C-reactive protein, SED rate, can be from inflammation anywhere in the body, although we tend to like C-reactive protein a fair amount for the GI tract, but it'd be from any place. Now, the other side of the issue is calprotectin may not be elevated in somebody with small bowel disease. So if somebody has small bowel disease, I suspect, although I haven't seen a stack of papers to agree with me, I suspect that the farther the calprotectin has to travel from where it's being produced there by the small bowel to where you collected it to tush, I think it breaks down over time. Lots of things break down the GI tract over time. So consequently, that may be why it's not as indicative of small bowel disease as it is for colonic disease. But you're basically, by calprotectin, you're taking a dipstick right where the inflammation is, and you're measuring it directly. So that's probably why that happened. Certainly, if things got massively out of control, some of the other things would also go up too.
Okay, we just have one more comment, and this one is for Zoe and Elizabeth. It just says, beautiful, strong young women, God bless. And okay, another one just came in for Dr. Rood. To follow up a year after small bowel resection and strictureplasty in small bowel, and a year on Remicade, which test is better to track inflammation in strictures, MRE or CTE?
Good question. The other thing you could say is colonoscopy if you have access. In other words, if the area that had a strictureplasty is near enough to what I assume is a connection between the colon and small bowel, if you can get at it directly, that's your best option. Probably both CTE and MRE are good. I might give a little bit of a hedge towards MRE for a couple of reasons. First of all, the difference between regular MR and CT versus the E part, which is enterography, is when you do standard CT, you basically get a silhouette of the bowel. In CT enterography and MR enterography, you get the thickness of the bowel wall. You can actually pull out the bowel wall by itself. And so I think if somebody who really reads MR very well, they may be better at picking up active inflammation from scar off an MR than a CT. The other advantage for MR over CT is the fact there's no ionizing radiation. So if you have somebody, Elizabeth and Zoe's age, who are going to be having their IBD for a number of decades, repeatedly CTing them with ionizing radiation over a lifetime is something I'd like to avoid. So I will tend to go with more MR in a younger person, particularly a younger woman, although I suppose the same would go for a younger man, to avoid the ionizing radiation. So the simple answer is probably MRE. The disadvantage to MR is it's a longer test. You're talking about half hour, 45 minutes for an MR versus a 10 to 15 minute CTE. Both of them will require you to drink a contrast so that it doesn't get you off the hook for that one. And it can be also based on the skill of the place that you're having it done.
Okay, we have one more question. This one's for Dr. Utterson. My 17-year-old son with Crohn's will either attend school in person or continue virtual. What's your opinion? Large high school population. I realize this is a touchy subject.
You're on mute.
You're mute.
Thank you. I appreciate you bringing up the part that it's a little bit controversial. I think it does matter what treatment plan your son is receiving, because certain of our medications make him more at risk of getting infections than others. And then it also depends upon if you feel comfortable with what the school has done with respect to following the CDC guidelines, because we would want to make sure that the kids wore masks, and that was mandated, not just our kids wearing masks, but everybody else. And we want to make sure that there was some way of, some social distancing, which may not be possible in a high school setting. So, if in doubt, we're kind of punting for the virtual, but the thing I want to caution everybody is that we're doing a pretty good job at maintaining physical health with kids. They're not getting sick like this, but we do have to watch their mental health. And so a 17-year-old boy sitting at home all day and all night is not normal. So we have to strike the best balance that we can. And it's not easy. Fortunately for us, the kids are doing quite well with this infection. We don't want them to get it and try it out, but they're doing quite well. And those patients that are on specifically Remicade and Humira seem to do well for the sake of they don't get the inflammatory reaction from the virus that we see other people get. And that's what causes a lot of the symptoms, especially the respiratory symptoms, all of the inflammation. So we think they'll do okay if they get the virus, but for a public health, aspect, we have to try to all do our part to try to avoid continuing any spread of the virus at this time. So it is tricky, but I think if you have doubts about how the school is handling it, and you have some other thoughts about social outlets for your child, then I think doing the virtual thing is certainly an option that's fine. Just need to make sure the mental health doesn't falter as much as we have control over at this time.
And going one step further, the drugs you probably want to think twice about are the systemic steroids. As you kind of picked up from my talk, we try to keep those to a minimum, but if you're on prednisone, the International COVID Registry for IBD patients show that your adverse event rate for something like prednisone can be as high as 1 out of 5. So in that situation, if you have an option between virtual and not, and you have a kid on fair doses of prednisone, it may be in this kid's best interest to stay virtual. Now, drugs like, as Liz said, the anti-TNFs by themselves, background bad things happening right now off the COVID register are about 6%, all comers, okay? And a bad thing for a COVID patient is being in an ICU, being on a ventilator, or being dead, okay? All comers. Anything that's below 6% with fair numbers may very well be protective, as Liz said, and that goes, the two drugs that hit that, or two classes, are the anti-TNFs by themselves, so Humira, Cimzia, Simponi, and Remicade, and the biosimilars for them, and Stelara. The anti-TNFs are 2%, Stelara's at 3%. Everything else is starting to push up towards that 6% number. I suspect that the numbers for the anti-TNFs won't move very much statistically, because out of about 20, I just looked at this last night, out of about almost 2,600 patients in the international registry, about 800 of them are in the anti-TNF group. That number is not going to move very much. So, but all this has to be taken into account of knowing your kid, knowing what your kid's going through, and judging what's going to be best for that child in that child's school situation that he'd be returning to.
Thank you, Dr. Rood, and thank you, Dr. Utterson and Elizabeth and Zoe. I just want to read one more comment that came in. I am very thankful for this resource, as we are new to IBD with our 11-year-old son. And I just want to say that's what these events are all about, to help patients understand their disease and understand their treatment options. So thank you all very much, and have a good evening.
Thank you.
Thank you.
You too.
Bye.
Thanks,
you.
Charles.
Bye.
Bye, everyone.
Bye.
Bye all.